Hello, everyone. I'm here with Dr. Tate, the first author of the new paper on incomplete mucosal layer excision during endoscopic mucosal resection that is coming out in the next GIE version. So, hello, David. Thank you for joining us today. Can you begin by summarizing maybe the primary focus and the findings of your recent study on incomplete mucosal layer excision during endoscopic mucosal resection?
Yeah, thank you, Diana. Thank you very much, and thank you to the to GIE for publishing our article and for giving us the opportunity to present this author interview. So we were interested in, okay, we know recurrence after EMR is a problem. We know that thermal ablation of the post-EMR margin reduces fourfold rates of recurrence, but why is there still recurrence? And is there some feature that you could detect within the post-endoscopy resection defect, which may be a predictor of whether a patient is going to get recurrence? And so that was the drive, and the multiple times the group and certainly the senior author, Professor Michael Burke, had identified this feature of what he called incomplete mucosal layer excision. And this, I think, was clear to him at the time that this was a risk factor for recurrence within the post-endoscopic resection defect. So we started to prospectively identify this finding, and we compared the rates of recurrence in patients with this finding to those without. We compared lesions, but critically, we compared also the histopathologic findings of those appearances. So we took those findings, this incomplete mucosal layer excision, which occurred, we re-resected it, and we sent it to the pathologist, and the pathologist was then able to analyze that and give us their interpretation of what was there.
Okay, thank you. And what were the key findings regarding the prevalence and the characteristics?
So we had 508 LMPCPs, or large non-pedunculated colorectal polyps in the study, median size 35 millimeters, and 2.0% of these cases contained incomplete mucosal layer excision. The histopathologic examination showed that 90% of these areas contained residual lamina propria. So that's interesting, right? Because we are trying, in EMR, at least with a hot snare, we're trying to get a submucosal excision. And in these cases, we were not getting a submucosal excision because the lamina propria remained. And muscularis mucosae also in 90%, and 50% of those contained residual adenoma. I think that because we re-excised all these areas, we didn't detect adenoma recurrence in follow-up, but I think this can therefore be described, given that when this sign was present, 50% of the time there was residual adenoma present. This can be regarded as a potential marker for recurrence visible in the post-endoscopic resection defect. So that's now okay. You have to finish your procedure, then you have to examine the margin macroscopically and remove any residual. And now also you should be looking at the post-endoscopy resection defect for this finding, and we've beautifully, I think, I can say that the pathologists have given us slides. There are beautiful endoscopic imaging in this publication, which shows you exactly what that looks like, and what you should be looking for. What is that? That is this kind of white appearance, white punched out area, or opposite of punched in area in the post-endoscopy resection defect, which is essentially the muscularis mucosa still there, and then occasionally, and in this case, in 50%, there is adherent adenoma to it.
Yes. So how would these findings then impact your clinical practice of EMR and surveillance?
Yeah, I think that it is a marker of technique. It's either a marker of lesion difficulty, non-lifting, fibrosis, or it's a marker of poor snare placement technique. So I think one, as a trainer, and zooming out a bit, that's a marker that your trainee needs to work on their EMR technique. Maybe they need to push down more, they need to take a bit more gas out, they need to get a bit more tissue into the snare. And Also, obviously, endoscopists should understand what this sign means. So that means that they don't just think, okay, I ablated my margin, fine, it's done. No, you need to bring in the resection defect as well. And re-excite areas like this, where you still see that the muscularis mucosa remains, and the probe remains, they should be re-excised because they are at risk of residual adenoma and the future. Of course, if you have multiple areas like this, which you identify, then potentially you should also think about bringing that patient back earlier for stroke, because we know that that's associated with adenoma. So potentially, if you're not sure you removed all those properly, then you should survey the patient definitely at 6 months or 4 to 6 months.
Thank you. Were there any specific challenges or limitations that were encountered during the study?
Well, certain limitations. It's a single center study, so that's the first thing, and a single. Mainly a single center study, and indeed also the frequency of this finding was not high, so that limited the power of other findings. It was retrospectively analyzed. I think that this finding throughout the study period became increasingly appreciated. So there is, of course, also the drawback that potentially throughout the study period these appearances were missed. And that the cohort contains hidden areas of IME that were not there. I do think the expert nature of the cohort mitigates against that, because likely that this is a non-expert phenomenon unless it's extreme difficulty. And the second thing, of course, is that we looked at those appearances and analysed them histopathologically and tried to make a correlation between histopathology and endoscopy. And I think that stands, whatever we think about the numbers and the detection rate of this finding here.
Mm-hmm. What would be the future directions or the potential areas of research following this study?
Well, I think we really need to understand what in the post-end, like why is it that big expert studies, the ACE cohort, whatever, shows that you can get recurrence down to 1.4% after thermal ablation of the post-EMR margin, and other studies, very nice studies, where people are educated to do EMR, but they're not super experts. For example, Leon Moose's group showed that this rate is at least 5 or 6 times higher than that after thermal ablation. So it seems that those practitioners start from a higher rate of recurrence. They still get a 4-fold reduction, but that rate of reduction is still down to a level which is much higher than this expert series. And this has to be explained by, or partially maybe, ablation of visible adenoma, but also probably from within the defect. So I think it's a very important finding for that, and it needs to be studied in greater detail, probably prospectively documented, and see what the rate of residual. Of course, you need to look at the rate of residual if you didn't resect it, and that's very hard because anyone who identifies it wants to resect it, right? It's the ones which are not identified which end up being recurrent. So difficult to do. A difficult problem to answer beyond my ability to give you that right now, I think.
Okay, thank you, David. So is there anything else you would like to add to this?
No, I think you just want to summarize by saying thank you to GIE, thanks PTN for doing the interview. And I think that the take-home message from this is look carefully at the post-endoscopy resection defects for many things, but in terms of recurrence, look for a potential sign which could indicate adenoma is still there. And if you see it, resect it.
Thank you very much.